Hello, and thank you for joining me today to talk about ECMO in patients with COVID-19 testing and challenge. I'm Lisa Baumann Kreuziger. I'm an Associate Medical Director of Versity in Milwaukee, Wisconsin, and an Associate Professor at the Medical College of Wisconsin. I have no financial conflicts of interest that are relevant to this discussion. I did create this presentation in collaboration with Dr. Justin Tawil, who is in critical care anesthesia at the Medical College of Wisconsin. Infection with coronavirus does lead to a coagulopathy. In SARS and MERS, we saw septic inflammation and DIC commonly. Acute phase reactants were elevated, including fibrinogen, factor VIII, and thrombocytosis, whereas in DIC, we see consumption, and so low fibrinogen and platelets and elevated PT and PTT. Initial reports of COVID-19 showed that coagulopathy happened more often in people who had a worse survival. So we saw coagulopathy in 50% of people who did not survive their illness versus 7% of survivors, and similarly with DIC. More recently, we do understand that the COVID coagulopathy does differ from the typical DIC, and how this starts is severe COVID-19 has a pro-inflammatory state with activation of endothelial cells and multiple other white blood cells, leading to a tissue factor mediated activation of coagulation. There's other pro-inflammatory responses that occur, and that leads to activation of coagulation itself. These images are taken from a beautiful illustrative review by Drs. Levy and Hunt in RPTH. And really what it shows is that the laboratory characteristics of severe COVID-19 include a mild to moderately reduced platelet count. This is most likely in the 100s, a mild prolongation of the PT, very high levels of fibrinogen, and a very elevated D-dimer. And the reason for D-dimer elevation can be a couple of possibilities. One is that there may be systemic thrombin generation and subsequent fibrin breakdown, leading to D-dimer production, or there may be a result of enhanced fibrin turnover in the lung due to inflammation. People with COVID-19 do have a risk for hemorrhage. In initial autopsy reports, they did see pulmonary hemorrhage that have been confirmed. We do see people with consumptive coagulopathy, including thrombocytopenia and low fibrinogen, and this, as you would expect, is associated with poor outcomes. And in the cohort studies that have been published to date, 3 to 11% of patients have had major bleeding. In order to frame the discussion about the risk of thrombosis in COVID-19, I wanted to first note the incidence of VTE and bleeding in critically ill patients who are treated with heparin. In prior RCTs, about 6 to 16% of people are reported to have a VTE event. In a cohort of critically ill septic patients, however, the incidence of VTE is much higher and was 37%. 1.7% of patients in this cohort also had major bleeding. Now let's compare that to what's been published in patients with COVID-19. An important distinction, though, with this data is that the incidence of VTE in COVID-19 is obtained either from retrospective studies or a prospective cohort study. There are no randomized control trials that are available yet. You can see that there is a very wide variety of incidences that have been reported, anywhere from 7.7% up to 47% of patients who are critically ill with VTE events. Major bleeding is noted between, again, 3 and 10%. You can see on the line in blue what the incidence of in RCTs of other critically ill patients, or in red in the previous sepsis cohort that I discussed. A meta-analysis of some of these retrospective and prospective studies have suggested an incidence of VTE between 27 and 31%, depending upon which model was used. When you see this very wide variety, though, of incidences, you wonder, are there different ICU criteria that are being used in discussion of what is critically ill? What other treatment are these patients receiving? We now know of the benefit of dexamethasone in treatment of patients with COVID-19, and many of these trials and studies have not reported other treatments that these patients have received in order to understand if that may have affected their risk for VTE. And then lastly, what's the threshold for testing within the institution? Some centers are using screening ultrasounds, whereas other centers it may be difficult in order to obtain imaging for thrombosis. And so this may also influence the VTE incidence reported within their institution. Many societies have now made recommendations regarding anticoagulation in patients with COVID-19, and you can see here a summary of what is recommended for critically ill patients. Most recommend prophylactic anticoagulation, whereas some have some leeway in allowing for intermediate dosing with some discrepancies of suggestions or consideration of intermediate dosing in critically ill patients. But what about ECMO specifically? ELSO guidance did suggest that ECMO should only be done in experienced centers, and they laid out specific criteria for patients who you would consider ECMO to be used, including PaO2 to FiO2 less than 80 for more than 6 hours, or less than 50 for more than 3 hours, or in patients with severe acidosis with an elevated PCO2 for more than 6 hours. Initial reports of outcomes of patients with ECMO and COVID-19 are limited. Many other reports note that people were treated with ECMO, but they do not specifically report on the outcomes of those patients. So in the cases that do note specific outcomes for patients with ECMO, the mortality is quite dramatic and ranges anywhere from a single case report of a successful use of ECMO to all of the patients dying within the cohort. There is an ECMO COVID Spanish registry that has been developed, and an initial report suggested that 55% of patients within that registry were able to be discharged from the hospital. In our local experience, what we have seen is that initially our patients were having an increased incidence of oxygenator thrombosis. So we increased our goal anti-10A using unfractionated heparin up to 0.3 to 0.7. More recently, we're seeing much more mucosal bleeding, and many patients are treated then without anticoagulation and or are reduced to intermediate dosing of unfractionated heparin with anti-10A activity levels between 0.2 and 0.5. So to discuss testing a little bit in more detail, we have options for testing, including our standardized tests that are performed in the central laboratory by skilled personnel and sample processing, and those tests would include the APTT and the anti-10A, or the PT, which is converted to an INR for use with warfarin therapy. We also have point-of-care tests that are defined as testing performed at or near the patient's site of care, and anticoagulation tests in this realm include the activated clotting time, or ACT, or viscoelastic testing, including TAG or ROTEM. So unfortunately, there's no perfect coagulation test. Believe me, I wish there was. So what you need to know is which test you're using, what that is actually measuring, and what are the pitfalls of the test that you are looking at. So the APTT measures the intrinsic or the contact pathway of coagulation. It also measures the common pathway of coagulation. It is done in platelet-poor plasma, so you do not have any effect of platelets. And this test is not standardized between institutions. It even is not standardized sometimes within the institution if different APTT assays are used for different testing. You will have a shortened APTT if you have an elevated factor VIII activity, which is something you could see in our patients with COVID-19. And you will have lengthened PTTs if there are other factor deficiencies, hypofibrinogenemia, a lupus anticoagulant, or other factor inhibitors. The anti-10A measures remaining anti-10A activity in the plasma. So what you are looking for is the effect truly of heparin within the plasma. Again, you use platelet-poor plasma. in this assay, so platelets are not a part of the assay. It is shortened if you have free hemoglobin, if you have elevated bilirubin, or if you have triglycerides, so that becomes important in our patients who are treated with propofol. It can be lengthened in patients who were previously treated with a direct oral anticoagulant and have residual anti-10A activity. Then our point of care assays, the TAG and the ROTEM, can look at different aspects of the coagulation pathway and use whole blood. They can have the same issues with factor deficiencies, hypo or dysfibrinogenemia, and thrombocytopenia affecting the testing. The ACT is poorly associated with heparin dosing, bleeding, or clotting. And similarly to APTTs, not all ACTs are the same. There are many devices that are possibly to be used, and the quote normal range is different with each of those devices. There are many confounders that will affect your ACT, including hemodilution, anemia, any factor deficiencies again, hypothermia, low fibrinogen, influences of your platelet function or number, as well as elevated D-dimer. So PT and anti-10A testing are preferred to ACT for monitoring of unfractionated heparin for our patients on ECMO. Because we do not know the most appropriate way to balance the risk of bleeding and thrombosis in our patients with COVID-19, I would highly recommend and encourage participation in one of the randomized control trials for patients with COVID-19. The ACTIV-4 acute trial is an NIH-sponsored trial that is open now and looking for sites. This is a multi-center adaptive randomized open-label trial to compare the effectiveness of antithrombotic strategies for prevention of adverse outcomes in COVID-19. The primary objective is to determine the most effective strategy to increase the number of days free of organ support and reduce death in patients with COVID-19. And the primary outcome is 21-day organ support-free days. And by organ support, we mean invasive or non-invasive mechanical ventilation, high-flow nasal oxygen therapy, vasopressors, ECMO, or death. And the current arms that are open include a randomization between prophylactic and therapeutic heparin. The clinicaltrials.gov website is linked below, and if you have any questions, I'd be happy to take them as well about this or any of the other ACTIV-4 anticoagulation studies. So some take-home points. COVID-19 is an inflammatory disease that has some differing features than your typical DIC. We do see an inflammatory state with elevated fibrinogen levels as well as D-dimers. There are both thrombotic and hemorrhagic complications in our patients with COVID-19. There is not any data regarding the best management strategy for our patients who are treated with ECMO. Please understand which lab tests you have available and your patient in front of you as you try to interpret those lab tests, including whether you use an APTT versus anti-10A. And lastly, please enroll in trials if you have the ability to do so.